following is a conversation with Dr. Simon Baunwall, a medical doctor and scientific researcher focused on fecal microbiota transplantation, also known as FMT. Dr. Baunwall is based in Arras University Hospital in Denmark. This conversation centered around the establishment of fecal microbiota transplantation as a therapy in Denmark. Simon talked to us about his work in establishing the treatment as a standardised, scalable approach using a blood banking type model, which is fascinating. We talked about his perspectives on how the field might evolve looking forwards, the next indication after recurrent C-difficile infection, the progression of FMT delivered by colonoscopy to capsules, and we had some interesting philosophical discussions around what is the mechanism of action and how do you define a dose? Because historically, what researchers have used is the wet mass of starting material, in other words, stool, that goes into the process. But what we discussed is actually that's probably not a good definition or metric for dose. We talked for quite some time. We went a little bit off-piste talking about other forms of microbiome intervention. We talked about the regulations as well, which Simon's been very heavily involved with. I particularly enjoyed this episode because Simon is a self-confessed, perhaps it's not a confession, but anyways, lover of the Inside Matters podcast. In fact, he has listened to pretty much all the episodes, so it was amazing to have a loyal listener onto the podcast to talk about their fantastic work in the microbiome and FMT space. Now, the podcast has actually been starting to get some really decent traction, and I'm pretty excited, to be honest with you. We started the Inside Matters podcast around about a year ago with the aim of giving high quality gut health content to all of the listeners. And that's what we're doing. We've done over 20 episodes. We're pushing 35-star reviews on Spotify, similar traction on other podcast apps like Apple. And we wouldn't be doing what we're doing if it wasn't for you, the listener. So thank you for supporting the podcast. Please keep engaging with us. If you've got any suggestions for topics or guests, reach out to us on socials or james@insidematters.health. This is Inside Matters. My name is Dr. James McElroy. I hope you enjoyed it. Why don't we start with how you got into this field? Because I don't actually know, so you should tell me that story.
Yeah, that actually one of my first patients I ever saw as a medical student back in the days was a patient who was referred for an FMT back in the days, and it was while it was still a very novel therapy at our institution, and I just saw the patient. Turns out that the patient did not have C. diff, but had a multi-resistant Klebsiella pneumonia instead. But we treated it anyway, and the patient was cured, and that just kind of got me hooked. And then, the classical story, back when I started, nobody really thought of FMT as something, and you saw the patients and you were just convinced. And we actually have this saying in our institution, the number needed to convince to see how many patients do you have to treat to be convinced that this is a good treatment that you have to progress with. And from then, I just started getting more involved, saw the issues back then. It was fresh donations coming in from dedicated persons in the lab. It was really something. And I remember when we had to do the first couple of procedures, the patient had to go to the hospital, stay in the hospital. The donor, who was likely the husband or something, or wife, had to come in on the morning, deliver. That was really quite a pressure, and everything just had to go right. And I thought, well, we can do this better. And
When was this in time sequence? So when did you see your first FMT as a medical student?
A medical student, it was back in 2015, actually. So I was quite in the run back then, and just saw it at the department. I was in a clinical stay, and I just met the right people at the right time, had the first patient, and just was absorbed and just started doing more, and been doing it pretty much since, to be honest.
And how did you progress then thereafter from medical student to doctor, and what is your current role at the moment? What does that entail?
Yeah, so right now, of course, I have a PhD and a medical doctor, and I'm working with the establishment of this clinical framework. So I have sort of established this, of course, with my colleagues, and try to make this FMT clinic and I have the role there. Of course, I have a position as a postdoctoral researcher as well, and still in training, but have this part-time research doing it on the side, of course. And we have this quite framework in Denmark now with the clinical infrastructure to provide FMT at almost all hospitals. So most of my time is also just coordinating efforts and how to make the guidelines and how to develop the treatment, how to make the procedure better, answer all the basic questions as well, and of course doing the clinical trials. So
if you take us back to what FMT was like in 2015, say, when you saw your first one, and walk the listener through the evolution.
Yeah, so back then it was really low tech. We had, in most cases, it would be the husband, and if the husband or wife could not deliver a donation, a dedicated person in the lab would willingly donate their own feces in this fresh container in the morning at the hospital, at a toilet, and then this donation would go to the lab for some processing, because in the fecal slurry there would be some elements of debris that would break a colonoscope if it was in it. So it would have this very simple initial processing. It would be pulled into syringes ready for application. Then when we knew this was ready, we would take the patient to the colonoscopy suite and make them ready and you just do the colonoscopy, and once in the right place, we would be called to bring this fresh material within a certain period. And I thought back then we said 3 hours, bring it to the colonoscopy suite, give the treatment, and then just administer it. But again, it started also the day before, because the patient has to be in the hospital. And if anything in this process go wrong, well, we could not do the procedure. And I think this involved about maybe 8 to 10 people just to make the procedure itself. And everything had to go as it had to if it were to be successful.
Right.
So it was really a development to see this obvious thing. We saw the patient get very much better, and just seeing the dramatical increase in health, in the general condition of this patient. But it was really a system that needed some hard work to just make scalable. And well, it was maybe manageable for 2 or 3 patients every 3 months, but it was really, really required a lot of effort and a goodwill on all the personnel as well. So
before we go into what it's like now and what work you've done and how it's improved, could you just talk the listener through what happens when someone's got severe recurrent C. diff and how quickly they can get better after an FMT? Like, what have you observed?
So the first thing, we have a lot of patients in the intensive care. Of course, we start with the most critical ill and try to reserve the treatment for those patients. And what happens is actually we go into given this whole procedure goes right, we'll go to the intensive care. In this instance, we'll not do a colonoscopy, but place a nasogeminal tube on the patient and administer the treatment and just cease all antibiotics, which seems quite brave for a patient in the intensive care, and really having difficulty. The expected remaining lifetime is not very long for those patients. And then we administer it. And in Denmark, we have this Big Brother watching, so we can follow in the journal, electronic journal, and you can see that within the next 6 hours, a lot of the leukocytes, which is quite high in C. diff because toxin A and B is a neutrophil chemotaxon, you can see that started to drop. You can see new notes on patients just improving, and the intensive care personnel not expecting this, and some would wake up starting asking for food, trying to pull out the tubes. So generally, we actually tell that probably within the next 24 hours, you will be better. Some will experience some severe symptoms that some would have a sepsis-like picture, but all of those would improve dramatically. And we expect to have some kind of a clinical response within the first 24 hours.
It's incredible. So are these people who've got an active infection, or have they been treated for their active infections through vancomycin, fidaxomicin?
Yeah. The patient where they are in an intensive care and it's a last resort option. Back in the first days when we did this, it would be on the active infection because it was the last resort. But today and more from the forthcoming, when we did not have to turn off the fire, so to speak, they would always be pre-treated with antibiotics, vancomycin or fidaxomicin, and metronidazole back in the days as well.
Yeah, back in the day. So I'll ask you an easy question.
Yeah.
What's happening that allows these patients to get better within 24 hours? And I guess I'm kind of asking you what the mechanism of action is, which is a bit sarcastic, not an easy question. But
well, the ones who will answer this will become quite famous, right? I'm not sure I'm the right one, but well, from a mechanistic point, there can be some learnings from this observation. That if we think this is bacteria working, well, should this work this fast? I don't think so, because it has to go into this growth of increased diversity, and they have to reproduce. So if it's working within 24 hours, maybe it's something else. And there's a lot of theories on that, but it could be have a lot of facets to it. It could be an immediate action, and then it could be engraftment of bacteria or bacteriophages, or there's some hypotheses. Also metabolites too. Yeah. There's been quite some good work on that, exploratory work, of course. But
could I just push you a little bit harder then? So if you were to take a guess yourself and there was a gun to your head and someone said, Dr. Baunwall, you've got to tell us how this works.
Yeah,
Where would you say?
I would say the phages or metabolites, but you cannot tell which it would be. But I think maybe it has this dualistic actions of both the phages and the metabolites at the same time.
Got it. So for the listeners who've hopefully just listened to the last episode with Dr. Indrani Mukhopadhyay, we had a long discussion about the virome and phages and the warfare that goes on between the bacteria and the phages 24/7, 365. So that's pretty cool. But what about from a metabolite perspective then? Could you go a little bit further on any of the work that you're excited about?
The group in London at the King's College with Ben Mullish and Julian McKessie has done quite some good work on this, where with the bile acid restoring the secondary bile acids, and I think there's a potential look into that. But it's of course this is all only for C. diff. For other mechanistic, I think we have to look at a more broader perspective, of course. But for C. diff, I definitely think there may be something about the bile acids.
Yeah, and that might explain why there have been some small numbers of non-clinical and clinical studies where they've taken the sterile, what they call sterile fecal filtrate, seems to have worked, although it's not placebo-controlled and so on. So
and we also have to, maybe a few bacteria would sneak in while doing those procedures, but there's definitely a lot less than in the crude FMT, so to speak. And the sterile filtrate, of course, has a lot of obvious benefits if it's true in the larger cohorts.
Agreed. And is there work ongoing investigating that at the moment, the sterile side of things, or?
I think there's a lot of clinical trials, actually, if you look it up. I think I saw at least 20 studies, but it's mostly in other conditions where you could have some safety issues that's, the long-term consequences of the bacteria, but that's definitely a good study to look into.
That would be cool. Maybe you should do it. And
maybe that's ongoing too. So
okay, cool. So tell me then about how the procedures evolved then, and talk the listener through how you've been involved in building things in Denmark.
Yeah, so actually my approach has also been to go from the cradle to grave approach, stating that, okay, if we have this effective treatment, but if we cannot supply it at first, it doesn't matter. If we don't have donors to provide for the treatment, well, we don't have a treatment. So going from the cradle to grave, I saw in the first studies I did was to establish this infrastructure and try to recruit donors in a more scalable way. And I started off with the idea with some of our colleagues as well in the blood bank system here in Denmark to say most of the screening panel actually were quite similar to the blood donors. So we started to see, could we recruit among the blood donors? And that turned out to be quite a good idea, because in Aarhus at least 300 donors come in a day, and they sit there already, and they have a lot of time to just go through the comprehensive questionnaire, and they are actually willing to donate almost everything. So for them to be able to donate feces on a more regular basis than blood were just something they really wanted to do. And I found that by going to the blood bank, we could actually supply and make this scalable. So suddenly we had a lot of donors, and from where there I progressed to the next and stayed, okay, the colonoscopy, the fresh donations, that was not feasible, trying to make it frozen. There was quite some good early studies by especially Elon Youngster that showed that frozen were of equal efficacy to the fresh, and there was also from the Finnish group as well some good publications, and we just moved on to that. And from where there we also tried, okay, now we have a problem. Colonoscopy nasogenital tube is quite demanding on the logistics, so having an encapsulated formulation would be quite beneficial. So we acquired some capsules and started testing them, and we really started off very poorly, but progressed into something, and now it's just capsules, and we're trying to improve on that every day, and it runs.
On the donor side, was every blood donor suitable for FMT donation?
No, that was quite surprising to us, that we found that around 20% of the ones who donated blood at that day was eligible for donation of their feces. So,
1 in 5.
Yeah, and we thought that would be much higher, but it turns out that blood donors, even despite stating before going to talk with me that, or the personnel now, of course, I'm feeling healthy today, but some would report gastrointestinal symptoms or have some carriership of something that we did not expect, and you can say they are asymptomatic. So how many have some of these symptoms in the first place? It's quite it was quite surprising to us, because we thought that at least half of them would be able to do this, but
absolutely,
and only a tiny fraction would reject or not say, I don't want to donate feces. It was on something like, we also have some criteria that we don't apply to blood. For instance, allergy was a major determinant. If you had any allergy, a history in any kind, you cannot become a feces donor, and a high BMI as well. So if you're a male in a good younger age and you're doing just a little physical activity, your BMI would be above 25. And we have a lot of difficult exclusion criteria, if you ask me.
So now we're getting onto the topic I was really very keen to discuss with you, which is what makes a good donor for FMT. Your reaction.
Well, it also depends on the indications, because we are also seeing that for C. diff, we see actually seeing a donor effect as well. So
really,
we are, when doing this large scale, I more think that we have to not talk about the super donor, but more go into the dilemma of some donors having a low performance. Actually, there's this average general level of effect, but some of the donors would actually perform quite poorly, or at least with 50% effect rates. And for FMT, of course, but you see the same for IBD, the inflammatory bowel disease as well. But if you that's more the efficacy road to answer the question. But you could also approach.
Let's hold on the efficacy for just a second, because there's way more to discuss. And then we'll get to safety, and we'll get to the sort of, is there a universal perfect donor? So on the efficacy then, so can you tell us more? If it's confidential and you're wanting to publish it, that's totally cool. But why are some donors worse than others, and why are some better?
And we have tried to examine a lot of this, and we are really still trying to answer it, and it requires a lot of power to have a lot of patience, because every time you add a new donor, you add a new you actually need a few donors with a lot of procedures to answer this question. But it's really hard to have donors providing for treatment in the 50 plus region as just doing 2,000 procedures. It's in that range you need to answer it. But we cannot find the obvious question right now, but we are looking into a lot of this.
Right.
But it's really, from a clinical view, and we also published on this, you can predict it, but it's not really sensitive to it. But you can actually state whether a donor may be effective or not. But we don't know.
So there's nothing really obvious, like, for example, if someone who's male sex donates and it goes into female age, nothing like that.
Not the obvious ones, no. And we always get this question, and it's really, if we could predict the good donors and do some good algorithms, we would be onto something, right? And I think
you'd have a company. You'd have a company to start.
Yeah, exactly.
You'd be the CEO.
Well, it's always difficult, isn't it? Because I also think the Italian group with Gianluca is onto something here to approach it from the basic mechanistic approach. But again, what makes the good donor? I think you have to state the clinical effect first and then trace it back, because it seems that there are no simple questions here, and maybe for C. diff it's more about defining the poor donor and stating what would not be the ideal donor in this instance.
Yeah, it's fascinating. So I think, for the listener, we've talked a lot about super donors, and it's always been in the context of being super good.
Yeah.
But what you're saying is actually they can be maybe not super bad, but they can be bad.
Yeah.
And I didn't even think that was possible for C. diff, to be honest with you, because the dogma has always been any donation, aerobic, anaerobic processing.
Exactly.
That's fascinating. That's really, really interesting.
And still, we cannot, when you look to the table of the donors and you see those who have provided for 40 plus treatments, which we can do, we just see this range in effect of them, but we cannot tell the magnitude of it. It's quite difficult, actually, and it's some difficult statistics to do, but we are trying to.
Are some donors universally bad?
Yeah, we have some. I mean, the thing is, we also see that some is not stable over time, actually. So some that has been good suddenly becomes poor donors, and you can do follow-up studies on this in the future, maybe to see those starting to get ill, or you have there's a lot of theories here, and it's quite interesting to discuss it. But
super interesting. So I'd like to now ask you about the safety side.
Yeah.
And I think we're going to talk about that for quite a long time. And then I'm going to bring it back to what our mitigation strategies can be for improved efficacy, improved safety, that kind of thing. So talk to us about the safety side then. And I think it'd be useful to hear how it started and where it is now. And you did a really fascinating presentation at UAG where you're basically saying, are we doing too much?
Yeah.
Which is quite controversial, I suppose. So
yeah, I tried to tease a bit there, because then you looked. Well, I think we have to go back to the beginning of the screening panel, and of course, starting out, we were transplanting human stool into deceased recipients with a immunocompromised, who is potentially immunocompromised. And from that perspective, everybody thinks, is this really a good idea?
Right.
And that's really the first approach. And what you do then is you go to the microbiologist and ask them, we are thinking to do this. And the first thing they will tell you, some of the more basic microbiologists will say, this will not work because all the anaerobic bacteria will be dead. And then you will transmit potentially all the pathogens you don't know. And then we say, okay, but what pathogens do we then know? And then we made a list, and we asked all who were specialists in bacteria, parasites, viruses, and made this sort of agreement to state we need to screen for everything, because we don't want a bad story, and we don't want to make the recipient even worse off. And that's how we started. But sometimes when you do that, you will have some contradictories in it. For instance, screening for something that if you start by asking a donor, are you feeling well? How many bowel habits did you have in the last 7 days? And there are some pathogens that would not be positive and when you're screening, normally you're screening a patient, but in this case you're screening a donor, and the likelihood of a false positive is really high. And sometimes we also have to look into that. So it's more, we have to start thinking, we have made this extensive screening panel, but does it really make sense, all of it? Of course, has been some stories, and especially the one in New England Journal of Medicine with the transmission of a multi-drug resistant organism. Well, that's something we of course should screen for, but there are some pathogens that you have to reconsider. And also, there will always be the skepticism around, are we transplanting something we don't know? Mm-hmm. Are we potentially inducing a cancer in 30 years or something like that? Right. And to answer the safety correctly, I think you always have to answer who is the patient, because for C. diff, what is the major safety issue with administering FMT? I would make a proposal to state that's recurrence of C. diff.
Agreed.
That's the highest risk, but when you progress to other treatments where patients are not that old and are not necessarily that diseased, then you have to reconsider the safety issue and also reconsider the indication.
Practically speaking, though, it becomes hard at scale if you have a different screening protocol for every indication. In fact, it almost becomes impossible.
Yeah.
In terms of chain of custody and, if you're doing one thing for patient X and one thing for patient Y, then it's a bespoke, almost personalized medicine for each patient.
Yeah.
And you know how much the personalized CAR-Ts and right? We're talking mega money.
Yeah.
So how do we reconcile that then? Like, what are your thoughts on that?
Oh, well, I think you have to do some minimal screenings, because when the thing about C. diff that's really nice is that either you have the disease or you don't. You either have the infection or you don't. So it's quite easy, or it's a model disease or infection to study the adverse events. So I think we have covered the short-term adverse events of FMT quite good now, with a lot of reporting of outcomes at adverse events. So I think it's strictly to state now that if you follow the screening programs, well, we can reduce the risk and mitigate the risk. But the things we don't know yet is the long-term consequences. And you have to follow the cohort to see, is there something that's more prevalent? But again, C. diff may not be the right indication for that, because, well, a lot of them are already frail, older patient, and their remaining life expectancy is maybe 2 to 5 years. So long-term effects it's not something we can study that well in them, I think. But for other diseases, we should do it, and well aware that we are doing it in knowing we don't know the long-term consequences, but we have to do a long-term monitoring of them. And that brings us to the regulatory part of it. And that's the reason, for instance, with tissue, like substance like FMT that comes from a donor, you have to follow for 30 years and keep the samples. So I think in 30 years we can answer some of it.
But there's this ongoing debate around what should we test for, how frequently should we test, and is there any more that we can be doing? So, for example, in the meeting in UEG, we had calprotectin came up with Professor Sokol. So how are you approaching that? And do you think we are doing too much at the moment? Is it over the top?
Some of the screenings are because it's because we don't have a differentiator into this. So we don't state you have to do this once and maybe every third year or every year if the patient goes traveling or something. It's every time you have to do the whole panel each time. So and when you have maybe in our screening panel of just the pathogen and the feces screening, I think we have 50 items. You just have a high risk of a type 1 error because you're doing it and you will have some false positive, and we see that. We see some donors who can repeatedly undergo the screenings, and some might argue those are the really good donors because they are the stable ones. But some donors may become positive for something, and then there's the ethical part. Are we doing more harm by making those really healthy individuals suddenly stating you have this intermobile coli in your feces and we cannot, and they always get quite scared when we tell, well, you have a parasite and that's the only thing they hear. And I try to tell them maybe that's a good sign of a high diversity and you're eating well, but it's always a difficult topic when you have this donor dependence. And I think the safety issue will always become, can we make the donor independent solution? And I don't necessarily think from a safety point you don't know how the donor independent therapies engraft and how they affect the recipient, but at least you know what you're giving or prescribing while doing
we're now moving into the future, which I'm absolutely keen to do, but I just like to linger on the donor screening side of things a little bit. So for example, the BMI over 25 then, so for the listener, essentially if you're a rugby player, you lift weights, you could be in incredible shape, 10% body fat, shredded bulk, but you're not allowed to be a donor. So is that kind of stuff going to change, do you think? And how is it governed? There are these expert groups, right, who sit and discuss. So
we had a lot of discussions on this, and I think we increased it to 30, but it's sometimes, and then you can find publications stating that if you have a BMI of 28, you're actually more likely to survive or something like that. I think we found a lot of material on that and decided that maybe 30 is the more rational. But again, it's based on consensuses, and you have to approach each item from the beginning, from the top to the bottom, and see how is it evidence-based. And there's a lot of discussions because even though by doing this, you will always find someone that does not agree with you. And it's not that the thing is, everyone is right in this decision, in this discussion, because if there's one who is transferred with a BMI that is high and gains a lot of weight, as we have a case report from the Americans in one of the studies, well, is that proof? Yes, that would, in the lingo of having to define adverse reactions, actually have to be defined and stated that you can potentially put on a pound of too much after the treatment.
And that would also suggest so that you can lose weight after an FMT, right? And I don't think that's been proven yet either.
No, but
so back to your own clinical experience then, how have the applications of FMT evolved over the years? So we talked about C. diff, but what are you investigating FMT for now? What are you excited about?
Yeah, well, always C. diff is a good model, and we're looking into some new indications as well. We are running a clinical trial of a decompensated liver cirrhosis, and we're doing one which also investigating a gastrointestinal neuropathy in type 1 diabetes. We're doing in systemic scleroma and multi-drug resistant organisms. And and we also have a new one, I think, that would be with we'll try to graft to see the immune checkpoint inhibitors, because it puts some pressure on us that there's some good studies and clinical trials showing promises, and the patient are trying to, writing us and stating you can do the treatment, and can I have the treatment at your place? And we always try to have it in trials to do it the proper way. So we're not doing it off label, for instance.
how do you select a potential indication though? What kind of discussions do your group have about, because the microbiome's been linked to everything.
Yeah, it's really the hard one, isn't it? We try to have the severity indication, that the indication has to be somehow life-threatening or so. This, for instance, the type 1 diabetes with gastrointestinal neuropathy, maybe it's not life-threatening, but it's invalidating to have so many diarrheas each day. And we have this severity indicator because we're also managing a lot of those indications does not have good therapies, and this would be a last resort option. So when there are no good alternatives, we would suggest or try to do it at least in the first place.
So you don't look then at animal model studies or sort of non-clinical work?
Of course we do that. We will always start to do a study, but we will not be the one doing the animal studies because we have to stop somewhere, and we are doing the clinical side of the things and look for the basic labs to do the first. But I think almost all indications by now have a microbiome related manuscript to stating some kind of a dysbiosis, right?
Right. And, gut health and the microbiome is now something that everyone's talking about. Back in 2015 when you did your first FMT. Nobody was talking about it, right? Yeah.
There were the Dutch group, the FMT study in 2013. Yeah. That was the only.
That was it, right?
And actually, in the first place, we also did it because we thought, okay, we had this patient, but did we really believe that you could cure by doing an FMT? And well, we reproduced the study and found exactly the same thing. So
incredible.
Yeah,
it's incredible. And within 24 hours as well, these super sick patients who are in ICU, literally coming alive again in front of you, just because you moved some microbes into their body. It's just
so the anesthesiologists all sometimes when we have been there could talk about the golden feces and have a lot of joking about it, and really impressed with this. So
yeah, because if all their parameters are getting better in front of their eyes,
and they're getting out of the ICU, so
I think the story that you started with like they're sort of comatose. You give the FMT and then they wake up and they say, "Get this tube out of me."
Yeah, can I have my favorite food now? And that was like actually quite the story. And I remember going home. I was not on the clinical shift then, but I had to look it up because stopping all antibiotics on a severely immune patient with a really severe C. diff infection that's fulminant, to me, that was quite brave, and I thought that it felt like I had to monitor, is this patient going to die or not? Because if we did not have done anything, the patient would have died. So,
and then you came in the next day and they were well? Is that what happened?
Yeah, we were called by the anesthesia, and I could follow in the night before going to bed that I could see there was this. The nurses were starting to make notes about they are starting to wake up now, and you can do the repeated sampling. You can see the leukocytes, it's falling and dropping to much better levels, and things are just. But again, this is of course in the active infections. I think with the recurrence, when they have some kind of effect, it's not this dramatic. But again, this is really the stories that convince us. So
absolutely.
To pursue this. So
it's unbelievable. Some of the people that I've spoken to as well off record have said that in the ICU they have given FMT to patients for C. diff, and incidentally their blood pressure started to rise and other parameters have started to normalize. And nobody can explain it. Nobody can explain how that's happening, right?
No.
But it's incredible. So have you seen similar? Have you seen blood pressure normalizing?
Yeah, we have seen it, and they have been dropping quite dramatically. We also done colonoscopies where in the first place they had pseudomembranous colitis, and then we do the FMT, and the day or two after, you can just see dramatic improvements in. And it's not that it's healing the intestines, but it's definitely doing something about the root cause of the problem, so the C. diff.
So for C. diff, it's kind of well established. And in Denmark, are you able to get an FMT product for C. diff now anywhere in Denmark based on the work you've done, or are you still working on it?
Of course, there's we have this in Denmark. We regard it as a tissue-like substances, and it's because of the donor dependency and not exploiting the donors that we just discussed, because there's really a lot of issues there that by putting it to scale and making it's trying to scale it, they have some concerns, the donors. What are my feces going to be used for? But actually we can do it in most hospitals in Denmark now, and we do it in our region. For instance, all hospitals can do it and do it every week, and I think we are about 1,000 administrations each year now.
Okay. And they're all ordering from your central manufacturing facility, or do they set up hub? Is it like a hub and spoke model, or you just want to build one big one?
We have 3 places in Denmark that do the processing and then deliver or distribute to other facilities. So try to simplify the process so the clinicians don't have to do everything with the capsules and produce them. So it's quite burdensome. And there's also something about the legislation and the regulatory approach. We try to centralize that part and then let the judgment of the treatments be on the clinician, and try to make it as easy for the clinicians as possible, of course.
Now, bringing it back to yourself, what is the focus of your postdoctoral research? What are you most interested in?
Of course, right now I'm trying to make the treatment available to most, because we also published in that it's really hard to have this microbiome therapy, microbiota-based research implemented into the clinic. So I believe that FMT is the first step, and then we have this more defined consortiums, and I see myself more as this is the first steps toward defining this microbiome clinics and try to establish this as something you have to use. And in the future, when more defined consortiums probably comes, but of course they have to show their worth, well, I would see myself at doing the clinical research, proving, it works. And I think you also have to have some kind of expertise for if it goes wrong. For instance,
right.
If you have a patient that's really deteriorating, you have to have some expertise in that. So that's what I'm trying to look into and do the clinical trials and see what works and try to answer the basic questions now, the doses and what count and how to do this in regular clinical work.
So are you defining dose as wet input starting material, or are you doing something maybe that could be described as more sophisticated?
Yeah, well, that's the good question, isn't it? How to do that? Because if you base it on wet dose, then after you have done a filtering on something that has a varying volume with a different fiber content, it's not really applicable. And we define it by the wet dose, but we are really looking into counting the microbiome or the microbiota, and we can see that that's probably the way to go for some, not stating that it's the bacteria working, but at least you have this concentration of for instance, you call it a fecal microbiota transplantation. So what we're trying to see is more all the DNA that's binding with the capacity and try to count it on a flow symmetry. So it's really what we're doing and trying to look into. And we see.
I did some work recently and I saw a range of 2 grams to 320 grams, I think is what I came up with.
Yeah.
So we're talking 2 orders of magnitude. It seems quite a lot, right?
And it is. So I think that maybe we are grasping it the wrong way. Maybe we also have to redefine or thinking of what an FMT is. And right now, an FMT is or an IMT, or what you can call it these days, is one single administration administered once. But for all drugs, for instance, vancomycin, you have 125 milligrams 4 times a day for 10 days. So that would be 40 administrations, or maybe for FMT as well, maybe you would have an induction course and then you have a maintenance course after that, but that could be the same FMT, the same treatment, but with multiple dosings. And
well, the key challenge there, I think, is if you're talking about the pharmacokinetics of a classic drug,
yeah,
it's metabolized and it's excreted.
yeah,
Whereas this is slightly different insofar as the active component, i.e. the bugs, are sticking around, right?
yeah, they're engrafting. So
They're engrafting.
from a biovigilance point of view, how do you approach that? Because you cannot say that after 5 half times the drug is out of the
Exactly.
body. So, and what about the safety issue? So, if you prescribe this defined consortium of this known bacteria, if that engrafts and it's with you for 30 years, do you have to follow the
Is
patient
that a
for
good
30
thing?
years? Yeah, is that a good thing? What happens?
One of my biggest issues with the Ceres product, Cera 109, also known as Faust, is you're essentially giving a high concentration of spores into the gut.
Yeah.
And it's only the spores. For the most part, it's shocked with ethanol. It's shocked with ethanol. And I always said, is that really the best approach to change the microbiome as a whole? And other companies, of course, are giving anaerobes and consortia and so on.
Yeah.
But very often you hear people say, well, of course, these defined consortia are the future and they're safer and so on. But are they really? And do we actually know?
It's easier for us to answer the question because you know what you're administering, and then you can track it. But I always ask the same question because I think you're completely right, and you don't know how these spores would interact with your microbiota and the native. But for C. diff, it's kind of this extreme state of dysbiosis, the hallmark disease of a lacking microbiome, and I think for this indication, maybe it's a good idea. But again, if you have bacteriophages, you need bacteria for those to feed off. So you kind of have to have a certain degree and some knowledge of the recipient of the microbiota before doing it as well. And there's a lot of assumptions in this that needs answering to state, is this really the right approach? Well, for reducing the number of multi-resistant organisms, is definitely a good idea.
Agreed.
But maybe from the mechanistic point of view and what we will find out, maybe not.
So where do you see the field going then over the next 3 to 5 years, based on the ongoing research and the work that you're doing?
Well, trying to extend the indication. I'm a quite keen speaker on trying to move forward FMT in the treatment pathway, of course, but that's because there's always this debate of what is working and not. But as a field as a whole, I think we'll be moving into this more refined consortiums, trying to standardize. I think we'll have some new treatment strategies in trying to have multiple doses. Maybe we would say something about an FMT induction with a follow-on maintenance therapy with multiple single smaller administration over days in the coming days after that. And of course, we'll see when we hit this new potential breakthrough in a new indication, maybe it would, I think, would be beneficial to the field as well. And I know you also have some thoughts about that, but I think that it's really about approaching this in the right way and doing it right, answering the dosing question, starting to discuss, okay, what is the dosing unit? Because it's not grams of wet feces. Maybe and it should not be CFUs as well, because much of the microbiota will not be able to colonize. So maybe we should find a new way to go about it to really see.
And how does the industry and the academic groups work together on that?
Well, I actually think this is an emergent field, and it's always starting with the clinicians, because they have the patients and they're trying to do the best for them. And I remember back in the day thinking, if there was just someone who could deliver this to me, I would gladly just take it and do it. And I was actually more forced to do the steps required to produce and bring this I think it was a really good therapy to the patients.
Right.
And I think that to really reconcile and do this better than the blood banks, at least in Europe, it has to become donor independent and be this defined consortiums, because I think that's the next step of how to approach the therapies. And if there's one day this better microbiome-based therapy that we believe is more safe and of equal efficacy, well, I would start using it.
No, but on the donor independent side, then, are you talking about single strain consortia of bacteria? Are you talking about phage? Are you talking about peptides? Are you talking about we take a stool sample and we make it bigger? Like, what is your vision for that?
We can start by saying what's the highest level that you can go through in some kind of refinement. I think that would be taking a stool sample from the recipient, matching it to what's lacking in, and finding donors or make a composite of this lacking bacteria, phages, metabolite, whatever, and do the personalized approach. But I think before that, we would need to do this defined consortiums with a lot of, you will have something that you don't need in it, to be honest. But you will have this interaction. And I think that it's also important to state that it's not just one bacteria. If that one bacteria to rule them all existed, well, we would have it already and you would be administering it. So it's not fecalium bacterium paucitini that we're trying to induce here.
Or I suppose the flip side is, I mean, on the single strain, it's kind of interesting, because if it was really true that single strains could just find a home and dominate and make you well, but the flip would also be true, which is single strains make you sick all day, every day. But it's not the case, right? It's a bit more complicated than that.
Exactly, and maybe the strains you need when you have the active infection or when you have the inflammation in IBD or something like that is something else you're needing. And I think we have to. I think the future is starting by making this platform that could work. That the clinicians has to somehow get the right samples, start to do the basic research, and then partner with the day. For instance, if you had the good idea and you knew this is the composition that's needed, well, this should not be in academia. It should not be a hospital-based treatment. It should be something produced, of course, in the industry. And I think we need maybe a better cooperation between the industry and the academia to achieve this, because that's where the next step lies ahead. Because I would say most of the current therapies are just pure luck. That's stating that lactobacilli may work and just try to use it broadly and do it and in the hope that this might work. Well, to me, if that worked, I would call it a hole-in-one, because you have not done the basic science. You have not, well, that you should eventually stumble upon the real. I know that antibiotic was invented this way in penicillins, but it's more in this way. I think we have to be more systematic in our approach to how we do this. And I think that's the future. And when we do this, we might have some answers that may lead us to the next series of ways to do this.
If you look at blood transfusion, though, we've been talking about a synthetic form of blood for a long time.
Yeah, well, at least 100 years, and it's the same with the plasma, and as well, synthetic plasma would be that's a huge industry, plasma donation, and that's huge, and I think we don't even know how that works. Maybe we could say this is immunoglobulins, but you don't know how exactly they are looking, and it's the same question actually. We know there's bacteria in the gut. We have an idea of the kind of composition, but even though you don't look like me and I don't look at myself over time, so it's really very common and very different in the same time, and it's really and it's the same dilemma. And the thing is, if we can move beyond the donor dependent, well, we could move ahead. But I think for every indication, we would have to do the clinical trials, maybe starting with FMT, trying to see what's working, and then try to purify.
And in the same token, you could take the industry stance, which is we're trying to create the safest, most standardized, highest scalability form of FMT IMT. And we're going to take steps, and there's controls, checks and balances to try and make it more effective and safer. And we're going to start with that, partner with the clinicians and other organizations, and try and tease out how it's working and refine and optimize.
Exactly.
So I don't actually disagree. I think the future ultimately will be donor independent eventually. But for now, I think we've got to hopefully, I mean, it could be 100 years, right? Maybe not with AI and all this amazing stuff that's happening.
But again, I think everyone always think I'm crazy when stating this, but I think that using FMT is a technology. It's a whole area that you cannot make a patent of trying to restore or disrupt, to restore or correct a disrupted microbiome. But is putting stool from a healthy donor to a deceased recipient really a technology? And yes, I would argue that, because it's has so much potential, and it's a technology in itself, and there would be patents, there would be indications, and a thriving industry, but nobody can claim it all because it's a technology. And I don't think the field would benefit from that. But I think we are at a stage now that's no longer 2013, and we have involved a lot of, when doing FMT, you have to see how many groups of different personnel you have to involve: industry, nurses, laboratory staff, and patients. And that's a really, and also I think there's a need for this cooperation and trying to extend the field. And I think we are at a point now, but I don't think the simple solution exists, because if we had it, if that existed, we would have it already.
We'd have it, right?
Yeah.
If you were to summarize what we as a field have learned over the last decade, so it was 10 years ago that the Van Noot paper was published in the New England Journal of Medicine.
Yeah. It's
kind of crazy, right?
Time flies.
I feel like I'm getting old. I remember reading it and I'm like, whoa, 10 years later, I'm doing this thing, and I'm speaking to you, who's also been involved for pretty much the same length of time. So what do you think are the key things that we've learned as a field over the 10 years?
I think that the thing is, you have to approach this from the beginning. When you're doing FMT in the first place, you will say, is this really effective? And the Van Noot paper ensured us this could be effective. Then the next question would be, is this really safe? And I think that in the short term, we can say now, well, it's safe. And then you will progress to say, okay, we have an effective treatment that's safe. How do I get it? How can I do it? And then we have answered most of that by stating capsule is a viable option, and you can do it on a high scale if you're doing it right. Donors will be willing to do donations for this. It would not be a taboo to anyone if you're doing it right. And then we will move on to the availability now. And I think in the next century it would be, or the next 10 years would be, the mechanism of, and that's the holy grail, isn't it? The one to be the first to answer just a tiny fraction would be, that would be the new Van Noot paper, I think.
Yeah, not a Nobel Prize? No, I think you're right.
Maybe if you could that, well, I'm not Swedish, so I know.
That'd be pretty cool, wouldn't it? It'd be pretty cool.
Yeah, and I think doing that could be what everyone's talking about. But I think we need to get the basic down, the dosing regimes. We need to answer the definition, the terminology. We need to get that in place. And I think that would be the next couple of years.
I'm fully aligned to you. We should collaborate. I do agree. I think it's dose. What makes a good donor?
Yeah.
How do we characterize the products beyond dose? So safety, consistency, that kind of thing. And then it's well put together clinical trials that seek to determine does this standardized composition. And by standardized, we don't mean that there's 30 grams of starting material in the product, right?
Exactly.
We've actually standardized it through proper controls, checks and balances, and then test it, right? Against the placebo with good sample sizes and so on.
And everybody that has been tried to work with making some preparing the suspensions know that wet weight is, well, it's the first step, and then you can do it anymore. So yeah.
Right. Yeah. No, I agree with you. So there's people that listen to this podcast who've got IBD.
Yeah.
And I get messages now. It's quite humbling, actually, how this has progressed as a thing, because it started off as being really just chatting to some colleagues and friends, having fun. Now I'm getting messages from patients and family members of patients saying, well, I've got IBD, what do I do? So where does the evidence sit at the moment for FMT and IBD?
Well, I think it's showing great promises now. Actually, I think that some of the later trials has been really, it's about the design of the trials that, having to do repeated administrations, that it's not an infection, so you cannot make a microbiota test to state whether it works or not. But I think that with the recent paper, the Lotus trial, that has shown that this is great promises, actually. And I think there are some key elements in this that I think that we have some questions to answer. What's the minimal dose? How should the treatment regimen be? But I think actually that the future trials would show to be positive, and I think that it would have a place in the future. And there are some obvious trials that needed to be done in this regard too. But I think it's again about the product not being enema and having to being able to have enough donors to sustain, and I think that has been the pitfall until now, actually, having the platform to do this.
Got it. And there's two ways to create the platform, right? One is do what you have done with your group, which is academic institutions, leverage the blood banks, and build up towards scale. The other approach is the company side, which is we're going to build a company to do this. And I don't actually think there's a correct way, because you're achieving impact. You're doing 1,000 treatments per annum.
Yeah, I think.
Nice.
I think it would be even more this year. I think it was 1,100 in the last year. So, of course, this is not procedures. It's preparation. So some would. It's not patients, but it's procedures. So some patient may require more, but it's in this scale now.
But hey, congrats to you for being involved in that and driving it. You're a key figure. Help us understand, how key are you in all of this, and where are your colleagues and such like?
Well, I cannot do this without, of course, there's the Christian Mass and Jens Svedred again. We also have a very good in our laboratory that has developed all of this and could not make it possible. But sometimes it's just seeing this and try to go out and do it, because a lot of this just happens to be simple but not easy, in that sense that and you really have to do it. And because we did not have any available product, and we were facing some severe regulatory issues as well, and I think that if you follow some basic principles, for instance, we have this EDQM where some minimal requirements for a safe product, and it's really about not messing it up for everyone else by doing, for instance, not screening for the MDROs. I think that's the thing. And in this, I have been part of establishing the common sense, I believe, and trying to scale it to the demand. And in the beginning, we did not think, okay, we're doing 200 procedure each year, we are at a maximum, we don't need any more than this. Then we developed capsules, and then it exploded, and we have a lot of demand, and we just tried to do it and scale it.
The demand you get, is it predominantly for C. diff, or is it now for multi-indications?
Yeah, we're trying to keep this stringent stating that you have to be a clinician to make to be able to make the decision that you should have an FMT. And it's just to avoid, this. It goes back to the safety issue of the severity of the disease. But sometimes we have some again, patients or their parents or their writing us, my mother is critically ill, can you help her? And we will do it sometimes, but it would mostly be in clinical trials, of course.
Can you get a private FMT in Denmark?
No, it's really hard, and it's because of the regulation. And but if you're in Denmark, for instance, we have a bank for donation of oocytes and semen as well. That's actually a tissue-like substance that's in the private company, but I think it's about reaching the scale where you can fulfill the minimum criteria is quite high. Or it's really difficult for FMT because of this screening panel we discussed. And how do you, as a private company, have access to this screening of everything that probably has to be licensed, and you have to have a GMP accredited facility as well. And I can't believe this headache in this department. And
yeah, I mean, I can talk about the headache if you'd like, because we've done it. It's a very significant undertaking.
Yeah,
and a very significant multidisciplinary undertaking. And to achieve the required level of verification, and ultimately for us, validation, is an enormous task. To validate every single pathogen on that panel for full validation.
Yeah.
Oh, okay. That's big. So I think I was just wondering if if you could get a private FMT, because in the UK you can. I'm not going to name any names.
No.
On the podcast. but you can, and yeah.
But I think it's again common sense, because I think that the ones who perform FMT should also have the capabilities to handle the potential adverse events. And it's stating that if you have to do it, you need some kind of a clinician to help you. It's not stating that the suspension could not come from some centralized part, but you need the clinician in the hand, and it needs to be within the right facilities and the follow-up. And that's actually what we are trying to state, is not trying to claim, but more claim some kind of a minimum safety, because some of the bad stories is actually home FMT, and it's, you really need to be able to screen, for instance, for multi-drug resistant organisms. But in Denmark, it's really hard. There has been some attempts, and it has just been too it has been too demanding right now. But I think with some of the consortium taking over, and it needs big money to do this. And sometimes it's easier to be in a hospital.
What kind of scale are you aspiring to be at with the service that you've set up? And also, what's it called? Have you got a name for your group?
Yeah, we are CEFTA, the Center for Fecal Microbiota Transplantation, and we started by stating that it was in Aarhus where we are located, but suddenly we tried, well, there's everywhere. You have to name the location. So I'm in CEFTA in this hospital. That could be in Aalborg. That's another hospital, for instance. So we are trying to do this center, but I think in the future we would develop into become the more clinical part of it, where patient would come and we would have this drawer of different treatments for different entities, and then be the treatment part. But right now, it's really hard for us to get the hands of just an FMT treatment, so we would have to produce it ourselves right now. Yeah. So I think it's about making the evidence, and then if we see that everyone with C. diff needs an FMT or an IMT or a defined consortium, well, I think every patient should have that. And in Denmark, we can monitor it, so we actually know how many patients with C. diff, for instance. In this region, it's around 800 patients a year. So in our region, well, 800.
That makes sense. And how many donors would you need, do you think, to supply the whole of Denmark? Like, to give the listener some perspective.
Yeah. Well, every day we have around 4 donors coming in. So,
yep.
And And well, I think to supply the whole of Denmark, but we have multiple places in Denmark where they produce and prepare FMT. But in total, I think we would need around 150 to 200 active donors.
Yeah, that makes sense.
And I think right now we have around 80.
All 80 through the blood bank and on the record and
no, we're about 1,000 now, but active donors that actually come in actively in donating.
Yeah, across the different sites. That makes total sense. So you're a microbiome expert. What do you do for your gut health?
Well, I'm trying not to do too much. Of course, eat healthy and do the right thing, but do we know, is it real? We have this notion that the most healthy person must be this young male in the 25 that's doing a lot of workout and has not been breastfed, had never had antibiotics. And sometimes I would state the obvious or the opposite. What about the one who is 65 years old, have never been ill, but have not eaten well? Is that a healthy, resilient?
Okay, so let me flip it back to you then, Simon. So let's just say, I don't know, you have to have an FMT.
Yeah.
And you've got two options. One is you have the FMT prepared using donated material from someone who's 25, they're in the gym, they're undertaking athletic greens, they don't drink, they're sort of fitness obsessed. The other is this 79-year-old who... So let me get this right. So you said they've got disease, but they've got a good microbiome, or
no, that can go through all our screening panel while being 67.
I got it. I'm with you. Yeah. So basically, it's someone who's much older.
Much older.
Whose would you take?
Well, from theory, maybe the 67 that can undergo the extensive screening and still
pass.
Multiple times, because that's actually quite the funny thing here. But we also have the age criteria. We don't have 67, but again, that could be. We don't know what's healthy here, and that's we're trying to make this. There's this publication in IBS from Norway where they have 200 procedures from the same donor. That's quite well described with this characteristic.
The super donor.
The super donor. The potential super donor, but I think we have to approach it from the perspective that maybe we should see what the disease is like and try to match it. But again, that's the future. So
how would we do that? Could we do that now?
Well, do we know enough? I think we have to state dysbiosis. That has not been done quite in many diseases. So you have to prove that there's a dysbiosis and see what's there lacking, and then you can do the matching. And for instance, Jasmine Bashaj has done this with the hepatic encephalopathy, and they try to do this rational donor screening based on what's lacking in the recipients. And it's hard to prove that this is correct, because then you would have to do a randomized trial by randomizing to rational donor selection and just donor selection from consecutive. But I think there may be something to it when we have the machinery and the computational power to do this.
And on that point, are you building AI into your workflows at the moment?
Well, I'm trying to see if I can build this assistant from the chat GPT, but I'm quite a keen interest in the endoscopy and to see how it can predict on the go and maybe assist. And I think we have so much data potential, and it's just about trying to use it. But
you mean your group has tons of data and it's about trying to...
No, in Denmark, we are really used to having tons of data. And it's because we have Big Brother watching in this big, databases that is electronic with all your health information. So in theory, you could train them and you could find all old, for instance, if you do a capsule endoscopy, you can have old footage. You can find that and match it to the history and try to train it. And
that's cool.
It's just waiting. And I'm not doing it, but a lot of groups in Denmark are doing it because they have this data available, and if you have maybe 2,000 tests and you can just train it to say, look for something that's positive here and it has been marked at this time point, well, but in the microbiome field, we still need some defining. So, but
what's
definitely,
important, what's not.
Yeah, do some unsupervised learning of the microbiome to see, could we find some pattern that we missed?
That'd be cool. That'd be super cool.
And we have done some of it, trying to locate the fingerprint of the bacteria that transmitted when doing the transfer of an FMT, and it's quite. But again, that's beyond me. I think I'm going to do the clinical part of it, and I'm trying to find some good partners for this. But it's definitely worth looking into.
Mm-hmm. Now, if you were to place some bets on what the next 3 indications will be for FMT after C. diff, what would you say?
Well, we might have one, but I can't disclose that.
Come on! Everyone's on the edge of their seat. We need to hear it.
Yeah.
No, it's cool. If it's confidential, it's cool. Maybe we can talk after. Yeah.
Maybe.
Cool.
But I think IBD would be, and we really seeing some, and also in the checkpoint inhibitors, we are kind of the story of us going into that is more the demand for it actually. And
from patients.
Yeah, from patients. We have a lot of patients writing us and trying
so for the listener, then these are patients who've got a cancer, which melanoma predominantly, so younger people for the most part, I suppose.
Yeah.
And there have been 2 papers now which have correlated enhanced effectiveness based on an FMT, essentially.
Yeah.
Right?
So they have this checkpoint inhibitor, which is a treatment that works in some of the patients with melanoma and some it doesn't work. And we cannot explain why it works in some and it does in others, but the common notion is that if it does not work, it would not work. So you either have an effect or you don't. And then they have tried prescribing FMT, and suddenly some of those that did not have an initial response suddenly had a response, but it was not in the C. diff area where it maybe of those patients, if you read the publications, it may be 2 or 3 patients, and being used to FMT for C. diff, that's not a good story, right? But when doing it for cancer patients with limited options, suddenly it becomes a good story, even the few that have it. So, and we also, but actually we are more on the immune-mediated side with the immune-mediated colitis on this part, because they have severe adverse events as well. So it's when do we approach these things? So it's some would develop immune-mediated colitis, and we will try to do that or treat those patients. But
so they've got diarrhea essentially, and we're going to give them an FMT. Yeah, that makes total sense. Will they get capsules?
Yes, and we have heard that history before about diarrhea, and suddenly you have to do something about it, right? So
absolutely, very similar to C. diff, and the capsules seem to work just as well, which is also very interesting.
Yeah, but we will still have to do, for every new indication, we'll have to do the dosing, the how to minimal. We have to, the mechanism of would always be the same. So for the new indication, so it's really there's a lot of publications coming from just starting to prove efficacy and then try to explain how it works. And
how it works.
And 10 years after the New England Journal of Medicine paper, well, we're trying to, for C. diff at least, defining how could it work. Know. Yeah, we still don't know. So, but
we can have this conversation in 10 years then.
Yeah, we should do that. That would probably be more uplifting, because now we're getting.
We hope so. We're getting there. We're getting there. We have made a lot of progress as a field, I think.
Yeah,
we have, absolutely. We for sure have, right?
Yeah.
And the industry have too, I guess. I mean, we can have a debate about how useful these drugs are. But there are 2 approved products in the US.
Yeah, and that's the Vaust and also the Rebiota, and I think they are both donor dependent, and
correct.
It's really the thing I'm looking forward, and I have high hopes for the ones that's donor independent, and there are some in the clinical pipelines as well, and
there are.
I think I'm looking more to them, to be honest, right now, because as a clinician, I think that would be really the interesting, and from the mechanistic part, it would also be very interesting that maybe it's these defined consortiums or proof of principles that maybe one of the treatment pathways or the mechanism pathways is this Clostridioides or Clostridia species that they're trying to restore. Some of
Could
the
be.
yeah could be.
But they're also missing phage metabolites,
Yeah.
peptides, fungi. So they're missing a lot.
Yeah. But I think, it's always the struggle. How do you get enough donors? Because you have the approved product, but
Yeah, I get it.
How many donors do you think it would require to supply the US, for instance?
Well, let me tell you this, or let me ask you a question. Let's say, for argument's sake, that the dose actually isn't 1 times 10 to the 11 and 1 times 10 to the 12 per gram. Let's say it's 1 times 10 to the 5.
Yeah.
Right? Then you only need 1 donor.
Yeah. But then you would have the problem if you're restoring everyone with the same donor, right?
Is that a problem?
Maybe.
Well, before we had this conversation,
yeah,
I would have said it's not a problem so long as the donor criteria got you a donor which is universally good enough.
Yeah.
However, what you've alerted me to, which I hadn't appreciated, and you need to publish something on this for sure, is there could be a super bad donor.
Yeah.
Like, then you have a problem.
We saw that because when we try to monitor the effect, we do the surveillance of the effects, and we actually saw this improvement. And suddenly, by doing blocks of patients and dividing into, I think we have 11 patients in each group, we can now do 20 because of the scale we do at. Suddenly, we would drop in effect, and sometimes we would have periods where it always worked. So. And we could not explain that, and we tried to say, is this, we are improving on the capsule protocol, and I can tell you, we really made a high effort to increase the microbial dose in the capsules. But after we had completed the study, 200 patients, a little less than 200 patients, the difference between the first protocol and the second protocol, they would completely equal in effect. But when doing the monitoring, on the other hand, the fluctuations were quite dramatic, and we could not explain it. But during the course of the study, we excluded 2 donors, and suddenly, at least for the following periods, the effects stabilized.
Wow.
But again, maybe if you just give 2 doses, maybe the donor effect disappear, and then it's just about doing enough. But we cannot say that. But we saw that, and we could actually see that some of the donors were below the expected.
Is there any parameter like diversity, for example, that you've identified which could quite easily explain this? The diversity dipped below 3 on the Shannon index, for example.
We are looking into that, but I can't disclose that.
I'm asking all the really juicy stuff now, but you can't disclose. Okay, well, you're working on it, and that's great. So just bring it back to you personally then.
Yeah.
So eating healthily, what's all of this taught you in terms of how to look after your own microbiome? What tips have you got for the listeners?
Well, I think sometimes you have to not be too absorbed with having a high diversity too much, because we are all individuals, and sometimes if you are stable right now and if you're feeling well and you're eating healthy and you're following the general recommendations, I would not try to correct too much, because maybe you're doing more harm than good if you try to supplement with something. But if you're feeling ill and you have some problems, I will try first, I would start with the diet, because what the microbiome feeds off is the diet. Try to correct that, see what works. Maybe you need a high carb, for instance, diet for your microbiome. What suits you may be individual, and that's maybe some of the reason why some of the diet studies has never been positive for long, because it's so individual. So if you find something that works for you, stick with it. And if you don't, try, but don't go out testing for things you don't know the answers for. So
Don't do
now,
a home microbiome test.
no, I'm against those commercial kits. And when patient presents me with the results, I'm always, well, I don't know what to do about this, but the pathogen you have there, I can treat the salmonella, but I don't know about the ratio of bifidobacteria to, well, we need to prove the implications before it can become clinical relevant. And patients should not just go out and pay thousands of dollars or euros for a treatment or a diagnostic that's, well, I understand they are desperate, but I think they should use the money for, you can buy a lot of healthy food for 2,000 euros.
I recommend that. I mean, I recommend the same myself. Buy the best food you can possibly afford. The at-home testing market, as you know, is kind of booming, and there's a couple of companies who are making, I'd say, good money from it. And it's really interesting to hear your perspective, which is you're a clinician, you see these patients.
Yeah.
The patients probably think they're doing a really good thing, and they might have saved up to do this.
Yeah.
And they're hopeful. They're coming into your clinic going, I'm really hoping Dr. Baunwall, he's going to tell me what to do. And they present you with this score or this report, and you go, I can't do anything with this.
I always look to the first page of those, because that's with the common pathogens in the screening panel, as we know, where, okay, they have been tested for salmonella and all the known, and sometimes it's actually positive. And then I can tell you, well, I can prescribe you some, we can do something. And then it always progresses to this ratios that has maybe been validated against some dysbiosis index that's IBS versus, for instance, healthy people. But again, then they apply this ratio to something else that's not IBS. Well, you cannot use it. You always have to be aware of what it's been validated before. And well, sometimes I can see, okay, I ask them, so you eat the same every day? And if they say, I only eat soup, I will tell them, well, I can see that. And that's the reason why it looks like this. And maybe you should diversify your diet. And I give them some dietary advice instead.
More fiber, more fruits, more vegetables.
Yeah.
Eat real foods.
Yeah, and try it. Sometimes you have to experiment with what's working for you, and more having consistent bowel habits. So you try, and it's more getting a focus on it. And sometimes I tell them, now you go home, you write a diary where you say how many times you go to the toilet and your symptoms. And then in this, you also state what food you ate this day. And then somebody comes back to me and we found, well, drank 2 liters of coffee, and then, well, that's probably the reason for the diarrhea. And so sometimes we're missing that. And
what is normal? How many times should one go to the loo a day?
Yeah, well, that's the exact question we're also investigating, and we're actually trying to answer that question. So
1 time a day, twice a day? There's this guy, Mark Hyman, Dr. Mark Hyman. He's a functional medicine doctor who's very famous. He's been talking about the microbiome since before the New England Journal of Medicine paper. He says twice a day. Yeah. You should go to the loo and do a poo twice a day.
Yeah. But we don't. The thing is, we don't know what's normal, and we don't have the normal bowel habit reference, which could be quite a nice one, right?
So we just don't know. Is that right? Is that a fact? Like we just.
Well, I have tried to. For some of the listeners, I would be very keen to have the publication. And the thing is, we need to know what's the healthy for the what's the normal bowel habits for the healthy. We have to make sure the ones participating are really healthy. We have to know that for them. They have to state something before even get the questions, I'm healthy today.
Oh, you're talking about for the donors?
Yeah. Or not necessarily, just for the general perception, what's a normal healthy bowel habit? Because the normal bowel habit has also to include the ones with diseases, because that could be normal for them. But we need the normal,
See what you're
healthy bowel habits. So
I see what you're saying. I see. I hear you. I see exactly what you're saying. So we have been talking for an hour and a half.
Yeah.
And we've covered quite a lot of ground. We talked about the evolution of FMT, future new indications, defined donor independent therapies. We've talked about safety, and we've also talked about your work specifically. So, is there anything else you might want to highlight to the listener that might be interesting for them or impactful for them as they're on this journey?
Well, I'm always asked about the regulatory part of this, and it's really a headache because I have been too much involved with this, spent too much time on it, and I'm not a lawyer in any sense, but sometimes we just have to acknowledge that, for instance, in the Europe and in the US, there's different legislations. So in US, also blood is classified under the drug legislation, and in Europe, it's more difficult, to be honest, and we have to acknowledge that right now it's coming out of a person, so it's a substance of human origin. Then it's a question, when do we make too much processes or apply too many steps to it for it to become more like a drug and should be regulated as such? And I think we also have substances that's both a tissue and a drug at the same time. And
yes,
and I think sometimes we have to acknowledge this is a tissue until it becomes something else. It's a substance of human origin, and then something else takes over, and it becomes. There's a lot of very broad definitions for this, and HMP, that's and there's a lot of synonyms, and it's just to state this dilemma: what do you do when you have something in grafting? And
so can I just push you a little bit on this? And I don't think maybe no one's ever asked you like this before, but is it really a substance of human origin in the true sense? Now, I know literally it has come out of someone's bottom.
Yeah.
Therefore, but the microbial elements are not human.
No, but it has been co-evolution. There's been an ongoing evolution in this, and it's also what you eat. There would also be some of your human cells in it. So if you could remove the cells, but I think the reason for this is not from the active ingredients. It's more to protect the donors, because in theory, the one I can counter ask you this: if you had the super donor, you were the super donor. Should I continue to donate every day so I could cure 200 patients instead? And then
I hear what you're saying. I get it, and I think what I mean, I can answer the question.
Yeah.
Look, we have to behave ethically and in keeping with all, good faith acting. So no, we couldn't contain somebody. What we could do though is collect donations with their consent and analyze them to the nth degree and try and figure out which elements are the ones actually driving the super donor effect.
And everybody should be doing that. And I completely agree with you. And the thing is, the reason why it's a substance of human origin and it matters is more from the donor protection part than it is from anything else. Anything else. So, but again, that could be private as well. We have companies in Denmark as well where you're donating semen. And you're getting paid for it, and so there's many layers to this, but it's more to acknowledge that we also, in this process, we try to focus too much on the patient and forget the donors and the rights of them. And some of the donors may feel obliged to come if I tell them, well, you are a very good donor. We need you. And we need this act of altruism where the donor independently, without knowing their effect, donate and do that on a willing basis so they don't get paid. For instance, we know from blood that by paying blood donors, suddenly we don't have hepatitis anymore and HIV in there. So you have to do it on that basis. And that's the reason why some of it has to be, when it's donor dependent, it needs to be, the donor part of it needs to be under regulation that's a substance of human origin. because that's not covered in the current drug
I
legislation.
understand what you're saying.
So
I get what you're saying. So there's a few different elements. One is protecting the donors, which makes sense. One of the other elements is making sure that the material that they're donating meets the sufficient levels of whatever it is we think are important in the context of critical quality attributes.
Yeah.
And then there's some forward-looking stuff around if you're taking the stool and subjecting it to levels of processing and you're presenting it as a drug, then it should be regulated as a drug.
Yeah.
But we're finding that bit quite difficult, aren't we? When does it become a drug is what we're finding hard.
Oh, we have been discussing that a lot. And I think it's when you're applying steps in the processing that's only for preservation. I think, for instance, if you're donating plasma, if you take your plasma and donate it to me, well, that would be a tissue transfer. But currently, you take plasma from a lot of people and pool it. And when you pool it, it becomes a drug.
Yeah.
So it's more definition. If you are making substantial changes to the origin of the material, then it becomes something else and has to be subjected to GMP, and you need to know what you're doing.
On the pooling side, I know we're about to wrap up, but we can keep going. So we need to talk about pooling.
Yeah.
And I'm an advocate, but you have a lot of experience in super donors, not so super donors, testing, controls. What are your thoughts?
Well, I think from a basic concept, if you're not speaking about efficacy, it's kind of a breach of concept, isn't it? Because if you're taking something from you and you're a good donor, this exact composition works in you. You're healthy. We know that from the screening, and you don't carry anything that's known pathogens. This exact composition, it carries some degree of that. This exact composition is healthy in you. But if you start to mix two donation, you don't know how they interact, and you will have some other. Then you're back in the laboratory and doing cultivation of something. You don't know how it would interact in the host. But by doing a single donation, you know this is a healthy in this person. So maybe from a concept, maybe it's a little bit safer. We don't know that, but it's more that we know this exact composition in this person is healthy. But from an efficacy point of view, I completely get the idea of pooling and trying to maximize the potential to have the most impactful bacteria or phages, metabolites, whatever. But it's more. You also throw out the potential possibility to answer what's working. So
I struggle with that. So I mean, I think just to put something on the table, I think if we could agree, I say we, the industry and the clinical academics and the scientists could agree that pooling was a fundamental step that made it a drug, because you have to pool safely, and that's actually really hard because you have to test every single donation for everything and have controlled pooling, and you have to do it properly so you don't skew the population. It's difficult. So I think that would work. I think the industry would say, yep, we agree. I think so. That would be one element of coexistence which we can discuss. But going back to the efficacy side, it's kind of interesting because you could say, well, diversity is a proxy for effectiveness, and the more people you mix together, the higher diversity you've got, and therefore you may have a better product.
That's an assumption. That's an assumption based on some of the IBD studies where a donor suddenly drove all the effect, and then they tried to mix it and had this more consistent effect rate.
Yeah,
and
donor B, right? Yeah.
Yeah, and it's the same for plasma. So if you have 50 plasma donors, they mix plasma from 50 donors, and then it's not a drug. It's more a substance. It is classified as a drug from the pooling and forth, but it's more consistent. Then we would say this is a consistent. And I actually agree with you that if you pool FMT from multiple donors, from the point of pooling, it would become a substance like a drug-like composition, and then it has to be subjected to the legislation. But before that, at all of the points until that would be a substance of human origin.
Yeah, I think I could get on board with that. I think, but I would need to have further discussion. And we should bring the groups together and have a debate. I'd certainly be very keen to.
I have been giving so many lectures on this. I actually made this graphic to simplify it in an attempt to do to explain this, because when you think about it, it makes sense. And the thing in this is almost everyone is right. At some point, it becomes a drug and should be regulated, but then it comes from a healthy person. So we also have to state that it is a tissue or a substance of human origin. And then we have to protect the donors. We all agree on that. So it's not that we don't agree. It's just we have to show how to pave the way for the regulatory approach to this. And I think pooling is a really good idea for efficacy, but does not tell you the mechanism of. Because
So but on that point though, if it is push you a little bit, if you've got one product that's monodonor and another product that's pooled, and you perform the same analysis on both, how is it better? How are you more likely to understand the mechanism of action with a monodonor product over a pooled product?
Because it would be likely more to characterize it. You would know there's no interaction in it, and you would be able to trace this fingerprint of bacteria, stating if the bacteria is present, this exact species is present in you, but has this deviation, then we could track it, and then you would be able to state maybe it's this mechanism. And I think that pooling is, of course, also maybe the future, but currently we're not ready for it because we have so many mechanistic questions to answer before going into this. Because if we could say it's all about metabolites, enhancing the number of different metabolites, well, I think we should do it. But we have to prove metabolites first.
Yeah, I mean, from my perspective, I think that you can do the same analysis on a pooled product versus a monodonor product. So I've always taken the view that as long as you do robust enough analysis.
Yeah, but you have to do really in-depth sequencing. You have to go to a much higher. It would be very costly. I think it would be too. I'm not the right to answer this, but I could imagine that the samples, the depth, sequencing depth would be close to. Yeah,
I take that point. No, I take that point, and I guess it's one for the industry. I suppose if we're all pooling, we need to do the necessary work to explain how our products work. And by the way, that is an industry headache.
Yeah, and if you're introducing a new donor, would that become a new drug? Would you have to get an idea as well? But
it's a good question, and from my perspective, the product needs to have a specification.
Yeah, and you have to make it broad.
It has to hit the specification every single time.
Yeah,
and the specification is not all-encompassing. And at this stage, it's also not down to the strain level specificity.
Exactly.
Right?
Exactly.
But yeah, I get where you're coming from.
So it's more if the active ingredient is changing, then it's a new product, because GMP has what it ensures is you have the same product every time. But the thing is how the tissue legislation in the SOHO is more to how you bring a heterogeneous product in the most safest way. It applies to the procedures around it, and it's not stating that the tissue legislation is for academics. No, it's also for it's also used by industry, and it's just because the industry is used to working with the GMP and the drug substances, and that's something they know. But it's difficult.
It is difficult, but you're making great progress, and you're having big impact within Denmark. And I wanted to extend my thanks to you for both listening to the podcast.
Yeah, I'm a keen listener.
But also, I really appreciate that. I really genuinely appreciate that. Having an expert like you listening to the podcast regularly is frankly a fantastic endorsement, and makes me feel really proud and really happy. So thank you for that. It's been a
I'm
pleasure.
learning a lot. Yeah.
I'm glad. Well, it's been a pleasure to have you on. I've learned a lot from this conversation.
Yeah.
If people want to follow you, where should they go to learn more about your work?
Well, I'm most on Twitter, or X it's called now these days, and I'm trying to update it regularly, try to post, and also have this profile of mine where I just add manuscripts, but it's always quite hard to read, so I'm trying to simplify things a bit, making it more available there. But on X, that would be where I'm most active.
Awesome. Thank you so much.
Yeah, thank you for having me.
Look forward to absolute pleasure, man. Absolute pleasure. I look forward to reconnecting, and we can discuss some ideas about collaborating and advancing this field.
Definitely would like to do that. I think.
All right.
Yeah.
Thanks so much.
Yeah, thank you.
Cheers.
Cheers.